Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Leonardi.
And you have yet another success story
Just launched by an East Bay fertility doctor.
Welcome to the Egg Whisperer Show. Today's guest is going to talk all about endometriosis, and he's one of the world's experts in this topic. Thank you, Dr. Mathew Leonardi, for joining us today.
Thank you so much, Amy, the Egg Whisperer. It's a great honor to be here and very complimentary calling me a world expert. I'm feeling not so sure about that yet, but that is a great honor for you to say that. Thank you.
I know you're very passionate about what you do, and I want your message about the importance of testing and getting the right answers when it comes to endometriosis sooner than later out there for the world. And I know that there's no one better than you. And that's what we're going to talk about today, the latest and greatest about endometriosis, and there's no one better than you. So I just want to share with our audience a little bit about you. You're an advanced gynecological surgeon and sonologist, which is basically an ultrasound specialist at McMaster University Medical Center in Hamilton, Canada. You also have you are simultaneously finishing your PhD at the University of Sydney, focusing on the utility of ultrasound in the diagnosis and surgical management of endometriosis. You're a nationally and internationally recognized leader in gynecological surgery and ultrasound, an avid researcher. You're actively contributing academically to the advancement of women's health. You're a sought-after international speaker on endometriosis. You're also appointed as the World Endometriosis Society Junior Ambassador in January of 2020 and a founding member of the Next Generation Committee at the International Society of Ultrasound and OBGYN. And you are currently contributing to the clinical practice guidelines on endometriosis for the Society of OBGYNs of Canada. And there's more, and an associate editor for reproduction and fertility and on the editorial board of the Journal of Minimally Invasive Gynecology. I call you a world expert. Thank you. So you self-identify as an endometriosis expert. Can you explain to us what is that so the audience has an understanding of what we're talking about before we get into the rest of your amazing work?
A lot of people who are listening to your show probably already understand the complexities around endometriosis. Endometriosis is a non-malignant or benign gynecologic condition that's chronic in nature. It affects probably up to 10% of people who are born with female reproductive organs. And so it's a really common condition and it's really complicated. It's kind of like gynecologic cancer, but it's not cancer. And it has a massive effect on people's lives to the point that their personal lives, their professional lives, their fertility goals are compromised. And so it is a condition, it's a disease that requires a really large amount of knowledge and skill, both clinically, imaging-based, surgically, and because we also don't know very much about it academically, it really is a disease we still have so many mysteries about. So I self-define as an endometriosis expert. There are a number of people around the world that also self-define as that. There's no real credentialing to become an endometriosis expert. Really, it translates to you have an immense curiosity about the condition and an immense interest in helping people with it.
And what led you to focus your work and research on the world of infertility?
Essentially, when I was a resident at the University of Toronto, I fell in love with gynecology and I fell in love with ultrasound. And those two worlds did not really collide very well. Of course, in the realm of obstetrics or, in the realm of REI and infertility, there's a lot more integration of ultrasound, but general gynecology doesn't really implement it. So I tried to bridge those two worlds. And I did international electives in the United Kingdom and in Australia. And I was exposed to people who bridged this world around gynecology, broadly speaking, and ultrasound. This is where I learned about the concept of a sonologist. And so I fell in love with this world of the two, and I decided to go abroad to Australia to do training. And so, of course, my main passion is in endometriosis, but endometriosis is a very common cause of infertility, so there is a very close draw between the two. Now, I'm not a fertility specialist. I don't do assisted reproductive technologies myself, but I participate significantly in the workup of those individuals and sometimes in the surgical treatment of those individuals who are seeking fertility as well. And so that's where I sort of entered this world.
Yeah, and I feel like more OBGYNs need to hear how endometriosis can be and will be for a lot of people a fertility threatening condition. And that's why what you're doing is so important. So I'm glad that we're able to bring attention to it today. And much of your work, as you described, involves both sonography and surgery to help patients with endometriosis. And your approach is unique, and I hope that it's going to be commonplace. But right now, it is unique in our field. And how do you use the two technologies together?
So it's unique in North America. It's not as unique in Europe, I would say. There are many different residency programs and consultants who practice in the realm of OBGYN around the world who actually do integrate ultrasound into their clinical practice. They have machines in their office, they see their patients, they scan their own patients. They don't have that same radiology sphere for ultrasound that we do in North America. So in Canada and in the United States, there is a quite large divide between gynecologists and radiologists, and there's not really that much dialogue between the two. And so truthfully, there have been lots of deficiencies in our own imaging potential for gynecologic conditions and endometriosis in North America. So as a sonologist, I both perform and interpret ultrasound for my patients, those who have pelvic pain or infertility or bleeding, other gynecologic entities. And one of the unique things is I give them the immediate feedback. I turn the screen to the patient and I point at the disease entities or their structures when they're normal, and I tell them they're involved in the ultrasound. After they are all cleaned up and dressed, we sit down and we combine the clinical information that I've acquired from them, the physical examination and the ultrasound information, and we come up with a personalized approach for that patient. Every person is different, and it's on the spot. So I agree. I want this to become the new standard in North America. It is going to take a long time for that to happen, but there are certain qualities of ultrasound that will allow it to happen. Ultrasound machines are getting smaller. They're getting more affordable. The learning curve for an OBGYN to learn gynecologic ultrasound is actually not that long because they understand the patients, they understand the pathology, and they understand things in different ways because they operate as well, right? Radiologists, as great as they are broadly speaking, they don't operate on these patients. They don't have the same intricate knowledge of the pelvis, anatomy, and the pathology that we do as OBGYNs. So that learning curve is relatively short. And one thing that I'm actively doing is integrating ultrasound into the education for the residents at McMaster University. I'm also speaking across the country as best as possible to encourage trainees to be open-minded to learning about ultrasound and starting to consider integrating it. There are barriers, but we just got to tear those down.
Yeah, absolutely. We should start a hashtag movement, pelvic ultrasound, please. I mean, I consider it my wand and my lasso all day long. All day long. I mean, I probably do about 30 scans a day. And the thought that a patient can come to me after trying for 7 years for me to find an endometrioma, like that just shouldn't happen. She should have known, with all those pelvic exams and pap smears appointments that she had, years ago. And you have a famous quote that I love, and I'm gonna share it with everybody. And that quote is, "Surgeons should not be surprised by what they find in surgery, and patients should not be surprised to learn of surgical findings when they awake." How can staying open to findings and remaining curious change the experience for doctors and for patients?
This has definitely become one of my most used sayings, and it has because as a gynecologic sonologist and surgeon, I have really understood that I can reduce my intraoperative surprises, really. What I anticipate getting into, I get into. What I tell the patients preoperatively and postoperatively matches. Of course, nothing is perfect in medicine, so occasionally there are some minor surprises, minor details, but most of the time, what I tell a patient we're going to do, we do. Therefore, they truly do make informed consent around their surgical procedure that they're undergoing. And you could even take one step back and say that information that's provided to the patient before surgery might even allow them to make other decisions that are not surgically related, maybe decisions around their fertility plan or their medical management. Not everybody has surgery. And so this concept to me is clear because I do ultrasound, and probably to you as well as somebody who has eyes on the end of the probe. For gynecologists who don't do ultrasound, they again have been exposed to some inadequacies in gynecologic imaging, and they are aware that surprises are a reality in gynecology. One of the things that I recall from my training, and it still comes up time to time, is how difficult it is to decide how long you're going to book a surgery for in gynecology, particularly when it's endometriosis related. It's like a guessing game. You know, you might think it's going to be complex and it's not. You might think it's going to be simple and then they have bowel endo. With the combination, you have a better ability to do that. And I think people who are working in this sphere would like this idea. They don't want to be surprised, right? So I think the concept just has to be sold to them that it's possible. And certainly from a patient standpoint, there's no convincing needed. No patient wants to go in, not know what's going on, and then be woken up. In particular, when it comes to endo and severe endo, there is no reason, in my opinion, that people should be having a laparoscopy and advanced disease is found at that time anymore. With advanced imaging principles, with ultrasound or MRI, we can absolutely and very reliably identify deep endometriosis, severe adhesions in the cul-de-sac, other forms of advanced disease where the ovaries are morbidly adherent to the pelvic side walls. These should not be surprises anymore. And when they're surprises, this really means that the gynecologist has not adopted those advanced imaging principles yet. And we got to get there.
I love it. And how does surgery help patients with endometriosis?
Well, this is a great question. So surgery, of course, is thought to be used as a therapy to treat the disease. But right now, surgery is also a diagnostic tool for a lot of people because they don't have access to good quality imaging. So one of the things I talk about a lot and I teach my trainees and my patients is it's actually quite difficult to discern what the therapeutic value of a surgery is when the diagnosis is tied to the actual intervention, the excision, the ablation, whatever the actual surgery is. Just today, I saw a post on one of the big Facebook groups about a patient who underwent surgery for endometriosis. She said in this post, "I have never been happier." She received a diagnosis. Post-operatively, she woke up and she was told she had endo. To me, this is quite strange. It's not strange in that people are happy to receive an understanding of why they have suffered. Nobody wants endometriosis though, so it's not a reason to be happy. But this patient should have not needed surgery to feel that validation. That should have come long before. So this patient who woke up and said, "I've never felt happier," how are we actually going to assess the true effect of that surgery on her symptoms when it's intrinsically tied to the diagnosis? So for me, I still believe that surgery is effective to help people with pain. Absolutely. Fertility is definitely a little bit more controversial, but in my heart of hearts, I do feel that surgery is effective for treating patients who have infertility associated with endometriosis. But the literature in that regard is a lot more controversial.
Yeah, I agree with you. I think that there certainly are patients that are helped by surgery. I've had patients who have done transfers on and they don't work, and then we pivot, we do a laparoscopy for endometriosis that we think that she has, and then she gets pregnant after that laparoscopy. But it is controversial. You're definitely right. So I love bringing new technologies to my practice, and that's kind of why I do this show, and I bring guests like you on. And I've been following you on Twitter, and I just love all the images that you share, just to teach everyone out there who's also following you. And I would love for you to kind of talk about what your novel technique is. And I know you have a similar interest in disseminating novel techniques beyond academic centers. So can you talk a little bit about what I'm talking about, your new ultrasound technique that might be useful in those with infertility?
In my time in Sydney, when I was working in the private ultrasound world for Professor George Condas, we did a lot of sonohysterographies and a lot of tubal patency assessments. And when the fallopian tubes were determined to be patent, the fluid, of course, travels into the pelvis. And it started to settle into the cul-de-sac, into that rectouterine pouch area. And so when it was there, I started to explore that area. I started to look at the peritoneum, the lining of the pelvis. I started to look at the uterosacral ligaments. I started to look at the dynamic nature of the bowel in that space. And I started to see these very minor features that were irregular. And I thought, what are these things that I'm actually seeing here? Is this endo? Is this adhesions? Is this previous pelvic inflammatory disease? We didn't really know. But when you come back to the population that this test is being done on, it was infertile patients. We know that patients with infertility have a very high prevalence of endometriosis, potentially up to 50%. And superficial endometriosis is the most common subtype of endo. And so it's these patients who I believe are left with this classification of unexplained infertility. So in this patient population, I started to look at that space. And eventually what we realized is we could see superficial endometriosis. Direct visualization of superficial endometriosis on ultrasound had not ever really been described. Soft markers for it have been, which means features that could suggest endometriosis, but not actually directly visualizing it. So Professor Condas and I and our team in Sydney devised this concept called Saline Infusion Sonopodography. Now, for those in North America who are not familiar with the POD, the pouch of Douglas, it's the other word for cul-de-sac or rectouterine pouch that's used in certain places in the world. So sonopodography means putting fluid, saline, into the pouch of Douglas and then looking on ultrasound. And we have done a study, a prospective study, where we enrolled patients who were undergoing surgery for endometriosis, did this test on them, and determined that we can, with a relatively high accuracy, see superficial endometriosis. About 80% was our accuracy. It's amazing because superficial endometriosis had never been seen before on ultrasound. And so for these patients, we're starting to think, we can introduce this clinically. And the perfect population for this is the infertility population for two reasons. One, high prevalence of disease. Two, they're already undergoing sonohysterography and tubal patency tests. All you have to do is, after the tubes are assessed, change the direction of the probe and look into the pouch of Douglas. So it's really relevant for this population. And one of the things that I'm going to be doing now that I'm back at McMaster is a prospective study in this specific population.
I'm just now thinking I can have my patients get their HSG done at the imaging center and then pop over here afterwards for their ultrasound, and there should be fluid there for me, and I'll be trying the same thing. And then I also thought, I've already titled your new book. It's called Pelvic Ultrasound, Please, by Dr. Mathew Leonardi. So if you need a publishing company, I can help you.
That's excellent. Thank you, Amy.
And then I've heard you also talk about the microbiome, and it's a very hot topic right now. So I'd love if you could talk a little bit about how microbiomes play into infertility.
The reason that I got into the microbiome was based on my interest in diagnosing the condition of endometriosis. We thought that there might be a specific signature of the microbiome that patients with endometriosis have compared to those without endometriosis. And so we could look for the microbiome features on a lab test and identify who has endo and who doesn't based on the patterns. Now, for those of you that are listening today, there's a couple things that are really important to know. The first thing is that there is a microbiome in the reproductive tract. Most people think about the microbiome as gastrointestinal. Really, that's the extent of it. But there is a microbiome of the reproductive tract, and there are people in the world that are working in this vicinity, and they're doing great work identifying the normal microbiome. If you think about it, the vagina is connected to the outside world. The vagina is connected to the cervix, which is a channel to the uterus. The uterus has a channel to the pelvis, which is the fallopian tubes. So technically, there is a direct link between the outside world and a pelvis that has open fallopian tubes. So there is a microbiome. That's the first thing. The second thing is that there is a relationship between the microbiome and estrogen. Dysbiosis, or an abnormal microbiome, may change estrogen levels in patients, and endometriosis is an estrogen-dependent condition. So that might have an implication on the disease development. There are lots of theories around why endometriosis exists. There's not enough time to get into all of them, but certainly there are immune factors at play. And so is the microbiome affecting those immune factors either directly or through the estrogen link? We don't exactly know. But this territory of microbiome and endometriosis, or microbiome and fertility or infertility unrelated to endo, is going to be a space that people need to watch in the coming years, I think. So the study that we did was firstly a review study. And this is where we did identify, based on the literature published, that there are a few specific bugs that are off, that are different in patients with endo. And for those that are keen, please do have a look at the article. It's called, I have it here open just so I can say the title, Endometriosis and the Microbiome, a Systematic Review. And we're also working in this space academically, doing a study on it as well, but that's to be seen.
Yeah, we'll make sure to have the article linked to the article that will go with this podcast. So for you guys who are listening on iTunes, just go to the comments, click on the article, and you'll read it there. So what are some of the biomarkers we might look for to diagnose or monitor?
Great question. And the answer is, unfortunately, right now, none. A lot of people know that there is some connection between endometriosis and Ca125. Ca125 is a blood biomarker that is more so related to ovarian cancer than endometriosis. But Ca125 can be elevated in people with endo, people with fibroids, people with other pelvic pathology. And so it's not a very specific test for endometriosis. And personally, I do think that it generally has more harm than good, because when people have an endometrioma and a marginally elevated Ca125, people start to get a little bit anxious. This again comes back to the limited ability of us to discern things on ultrasound, or at least currently where things are at. And so if you have uncertainty on your ultrasound report, you have an elevated Ca125 and an ovarian mass, you're going to be worried about a cancer. So then we start to refer people to the gynecologist, and these patients go down a path that's very anxiety provoking and often for nothing. So I really don't encourage people to use Ca125, but I think it can still be used in a research setting to try to identify patients who have the superficial endometriosis subtype. Personally, I think biomarkers are not going to be so helpful in diagnosing deep endometriosis or ovarian, because ultrasound can do that reliably. And really what we need to do is introduce education and teaching for people to start doing those tests. Biomarkers are going to be useful for those who do not have very easily visible disease on scan, but have symptoms. And Ca125 could be a potential player. There's another one, VEGF, that has some hope. And that's because endometriosis is connected to the development of new blood supply called angiogenesis, and VEGF or VEGF has a connection to that process. So there's a couple that are hopeful, but none that are ready for prime time.
What about genetic tests? Are there any genes that you've seen that could kind of tell someone if they have inherited an increased susceptibility to endometriosis?
It's a good question. We do know that there seems to be a predisposition to endometriosis when female relatives have had it. But as far as I'm aware, there's no genetic testing as yet that's going to tell us that. One of the areas that I'm working on with one of my colleagues here, Dr. Jocelyn Wessels, and as well Dr. Lauren Foster, is to look at the microarrays of patients' inflammatory markers. And certain inflammatory markers are going to be elevated in patients with endometriosis. And so we're getting closer to the basic science, smaller nitty-gritty work. it's really not my specific area. These are my colleagues that are leading the way on that, and I'm contributing. But we're starting to look at the smaller and the smaller and the smaller to try to understand. So it could be in the future, something that's possible, but right now, nothing that I'm aware of.
Yeah, no, I agree. I mean, there have been companies out there that have proposed, gene tests for endometriosis, but it doesn't seem to be ready for prime time quite yet. So I understand you're also researching other alternative management strategies like physiotherapy, medical cannabis, and psychotherapy. And how did they work with patient care?
Yeah, this is really the new world for me. So when you go to med school, you don't learn very much about complementary and alternative management strategies. I think we had one lecture, and then you go to residency and you still don't really learn very much. I was introduced to the concept of pelvic floor physiotherapy, I think as a 5th-year resident, but at that point it still seemed extremely fringe. Then I went and did my fellowship and really started to see the utility of that physiotherapy in patients with endo. My relationship that I have developed with Dr. Mike Armour, who is essentially quite holistic health specialist in Sydney, he has opened my mind to the utility of things that are not traditional, really, not what our med schools and residencies teach us. He does acupuncture for patients. He has taught me a lot about cannabis. And so it really opened my mind. And so now in real life, in my clinical practice, I refer almost every one of my endometriosis patients who has pelvic pain to a pelvic floor physiotherapist. The pelvic floor muscles are intrinsically connected to the endometriosis process. They become a huge source of the pain. And so we cannot look at endometriosis exclusively as a lesion, a spot of endo. It's bigger than that. We have to treat the lesion, we have to excise it or treat it medically or both, and we have to integrate the allied health professionals. So physiotherapy is a big piece. I integrate diet into my care because lots of our patients have gastrointestinal symptoms, bloating, bowel movements that are abnormal. They have pain with bowel movements. So dietary modifications are very helpful. And so more and more that network of allied health professionals is growing. For me, at the end of the day, if a patient finds something that works well in a multimodal approach, that's amazing. We know how hard endometriosis is to treat. So if we can find more things that work, wonderful. Like that's nothing is ever going to take away from us as traditional Western medicine doctors, but we need to be more open-minded to this. So right now, the work that's being done academically is more in the realm of understanding what people are using, how they're using it, why they're using it, and eventually we'll be able to start to understand the true efficacy of the various interventions by doing randomized controlled trials or high quality cohort studies. But right now, nothing like that is actually happening at my center.
Yeah, I like that you use the word fringe because a patient the other day said to me, I was recommending something along the lines of what you said, and she's like, that just sounds weird. and then I'm like, okay, I'm the weird fertility doctor. That's fine. I'll take it.
Weird to me translates to forward thinking, outside the box, trying to find solutions that maybe have not really been considered. So that's compliment.
Thank you. So is there anything else you'd like to add to today's discussion for our listeners?
One of the things that I really try to encourage my patients is to advocate for themselves. Endometriosis and in general, gynecologic conditions are not really that well researched. They're not really that well supported with resources in clinical settings. Gynecology departments are never as big or well funded as cancer departments. And so we need to speak up as a group of people who are either the patients or who are the providers. And so advocacy is really important. And I've seen through social media that the patient can really drive forward the agenda by being a voice. So I really encourage people to be an advocate for themselves in their own clinical care, but outside of that as well, be an endo warrior. Do participate in any research opportunities you can. Use your voice to make change. And that's how I think together we'll be able to continue to push forward this field of medicine, which really does need a lot of pushing forward.
I agree. Well, thank you for that. And where can people find you and your work?
Lots of places. So I have a website. It's my name, Mathew Leonardi. My name has one T in it. And so you can check me out there. But I'm also on Instagram, Dr. Mathew Leonardi, Twitter, @Mathew Leonardi, Facebook, Dr. Mathew Leonardi. And I have recently started to put up some of my talks on YouTube. So if you pop my name into the search bar on YouTube, you'll be able to find some of my educational material there. Again, really trying to give people in the lay population the knowledge, the tools, so that way they can start to advocate for themselves with their own doctors wherever they are in the world.
Great. Well, thank you. I'll be subscribing to your YouTube channel today.
Awesome. I'm already subscribed to yours, I think.
Well, thank you. Well, thank you for joining us again. And thank you for all of you who are listening. And we hope to have you back on the Egg Whisperer Show, Dr. Leonardi, talking about endometriosis and all your research in the near future. So thank you for joining us.
Thanks so much. Pleasure to be here.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Avazadeh.
And you have yet another success story.
Just launched by an East Bay fertility doctor.